All right, I'm going to go ahead and start the Shock and Mods video here for you guys. I may have to stop it periodically throughout and we'll restart it. Important stuff for you guys to know is obviously the classifications of shock. I'm not going to read this to you, but obviously you're going to want to know your hypovolemic, your cardiogenic, your septic, your neurogenic, and your anaphylactic. What is shock? What's important for you to know is that shock is a condition where the tissue perfusion is not adequate to deliver oxygen, nutrients, or support vital organs or cellular function. It's going to affect every part of the body. So all body systems are going to be affected. So when we say, what are the implications and what do we need to do, you're going to see that there's common threads. It's the vital signs, it's the labs, it's the CBC, the CMP. There's a lot of different components. We're looking at, their cardiac assessment in all of them. We're looking at their fluid status. We're looking at, are they, hypotensive? Are they tachycardic or bradycardic? Because you're going to see as we go that is going to be where you determine what is wrong, which type of shock it is. So we'll get into that more as we go, but it's really important that you understand that each shock is classified in a different way, and that also what you want to make sure you're looking at is how you differentiate one from the other. And hopefully with all of the questions and everything that I'm giving you in here, you should be good by the time we're through here. So your pathophysiology of shock. So read this question. And what you want to remember is the answer to this one is B. And the most important thing is we said the cells are not going to get blood supply and are deprived of oxygen and nutrients. So when a patient is in shock, everything moves, it's diverted in other areas. And the biggest issue is that the cells are not going to get oxygen and nutrients. So the patient's going to have issues. So pretty much any time you have this, you're going to have someone who has a low O2 sat, so you're going to want to put oxygen on them. We're going to end up needing to give them fluid replacements or some type of fluid. So that's one of the most important things, is that the cells are going to be deprived of oxygen and nutrients. So the cellular effects of shock, and this is in your book. Sorry, I'm just flipping to the page here. You are going to look on page 287. So really what you're looking at with shock is when someone has normal cell function, that's obviously on your left side, and when they have the effects of shock, they're going to have swelling and edema. Sorry, I'm trying not to sneeze here. Really with the lack of blood supply and oxygen and nutrients, what's happening is there's, the low energy, the cell will swell and the cell membrane gets more permeable. It lets the electrolytes of the fluids to sweep out and into the cells. So there's instability of the cells. The sodium potassium pump's not working. Cellular structures aren't working. Everything's damaged. So it's really important just to know that from the cellular level, your potassium might go out into the cells. You might end up with a patient, who has hyperkalemia with this, which is obviously common. You're going to have, the permeability, so the fluid's going to go in and out without much regulation. Your compensatory mechanisms, that's on page 287 as well. So again, you have your initial injury or insult that leads to shock, whether it's an MI in your the cardiac shock, or whether it is an infection in your septic shock, if it's, bleeding that leads to hypovolemic, whatever it is, that's your initial insult. That leads to your decreased tissue perfusion and the decrease in your oxygenation, and then the activation of the homeostatic response. So whether it's your sympathetic or your parasympathetic, and what's important is your sympathetic response is what happens in almost every single shock except for neurogenic shock, and we'll talk about that when we get there. You'll almost always see you're increasing your heart rate, you're increasing your blood pressure, you're increasing contractility to get that cardiac output up. We're either going to restore perfusion or it's not going to be effective. So what you'll see, again, when we talk about neurogenic shock is your parasympathetic nervous system is what's activated instead of your sympathetic. So the big thing with the neurogenic that's different from the others is that you end up with a decrease in the heart rate. The other thing you'll see that the respiratory rate, when they're homeostasis, when it's happening, their respiratory rate's going to decrease and their oxygen set and delivery is going to stay up. When they're not compensating anymore, you're going to see the opposite. The respiratory rate will increase and oxygen saturation is going to decrease. So that's how we would compensate in normally. If we're not compensating, we're going to obviously see the differences in this. And we'll go through those one by one as we get through the slides here. So our stages of shock, that is discussed starting on page 288 in Brenner's 13th edition. We'll talk about the compensatory, progressive, and irreversible stages. And I'm going to go through those one by one. But just so that you know in your book what you want to start looking at for this to go through as I'm talking about it is 288, and it ends on page 292. So those are the pages that we're talking about. When we have a patient who go ahead. The emergency nurse is admitting the patient experiencing a GI bleed who is believed to be in compensatory stage of shock. What assessment findings would be most consistent with the early stage of compensation? So where you're going to find this is on page 288 under your clinical manifestations. When you have someone in compensatory shock, they tend to have a normal blood pressure. Their heart rate is usually high, so they're tachycardic. Their respiratory rate is also usually high. Their skin is usually cold and clammy with a decreased urinary output. They're often confused or agitated, and their acid-base imbalance is usually going to be respiratory alkalosis. So your answer to that is going to be D. It's a very common question when someone's talking about the compensatory stage of shock. They'll be cool and clammy. So again, we said our sympathetic nervous system is going to be what usually works. And again, I said there's one type of shock, which is our neurogenic shock, where it's a little bit different. But for most of the shocks, what you want to remember is your sympathetic nervous system, which causes a vasoconstriction, your increased heart rate, your increased heart contractility. Remember, your sympathetic nervous system is your fight or flight. That's what the part of your autonomic nervous system that signals your fight or flight. By stimulating, sorry, I am not feeling good, so I apologize. By stimulating that fight or flight mechanism, it's going to maintain the patient's blood pressure and their cardiac output. So that's what's really, really important in this phase. The body's going to shunt the blood from the skin, kidneys, GI tract, resulting in the cool, clammy skin. So that's why we get that cool, clammy skin. You'll also find during the compensatory stage, which is that early stage, that the patient is going to have hypoactive bowel sounds, because remember, everything's going to maintain our organ systems, our GI system's not the most important thing right now. So we're going to shunt our blood away. We're going to also have a decreased urine output. We're having an increase. We're trying to increase our cardiac output by decreasing our urine output. So our kidneys aren't going to be saying, hey, let's pee, because we're trying to get everything in towards the heart and the brain and maintain function. Perfusion of the tissues is usually adequate at this point, so you're not going to see any decrease in capillary refill. You're going to feel pulses. So you're going to have good perfusion to the tissues. The patient's color is still going to be okay at this point. Acidosis occurs from the anaerobic metabolism as things are starting to progress in this stage. Your respiratory rate is going to increase due to the acidosis, which is often going to lead to what we said is that respiratory alkalosis. So the acidosis is starting to happen, but our body's compensating, and sometimes a little too much, to put us in a respiratory alkalosis. Remember, that's on page 288. And again, we said the patient might be confused. Sometimes they're not even just confused. Sometimes you'll find that they're actually really irritable or cranky. So when you're evaluating a patient who's at risk for shock, any change in mental status, whether it's even just a mood change, you want to kind of be in tune to that so that you are able to catch an early change as the patient's getting sicker. Go ahead and read this question. So again, we just said they have the increase in their heart rate, Their blood pressure might be normal at this point in time. So it's often missed because you don't see the change in blood pressure. And we'll talk about septic shock a little bit more when we get further on. But that normal blood pressure is often that deceitful thing that you find. The increase in their heart rate, their decrease in their bowel sounds, and that cold, clammy skin should be your sign that that person is in that compensatory stage of shock. So they're in that first part of shock. Again, like I said, it's often missed because that blood pressure is normal in the beginning. You want to always be doing a really good assessment. And I know a lot of you have said, well, the nurse didn't do this or the nurse doesn't. You do it, because you listening to those bowel sounds every time you go in the room, you might catch the shock. You know, when you talk about septic shock in this case, you have that window of opportunity. Within that first 6 hours of sepsis, you need to be treating that patient. So it's very, very important that you're doing this on a regular basis. And why I always say to students, get in the room and have your assessment done within the first half hour of taking over for another nurse. You want to put your eyes on that patient. You want to listen to the bowel sounds. You want to see what their urinary output is. You want to see what their skin looks like, how their mentation is. So if there is a change, you have your baseline. So again, that compensatory stage of shock, which is talked about on page 288 in Brunner's 13th edition, what's super important is that progressive, you can lead to the progressive stage, but in compensatory, your blood pressure is normal. They are tachycardic. They don't have strong bowel sounds. A lot of times the urinary output is down, and they have that cold, clammy skin. That mentation is sometimes one of the early signals too. If they're a little bit irritable, more irritable than they've been, or if they start to seem confused, always be thinking, could it be shock? As we get to the progressive stage, go ahead and look here. And this is in your book on page 290. So your nurse is transferring the patient who's in the progressive stage of shock into ICU from the medical unit. The medical nurse is aware the shock affects many organ systems and that nursing management of the patient will focus on what intervention? So basically it's going to be B. And what's important in the progressive stage of shock is that we need to figure out, assess and understand the shock, figure out what kind of shock it is. And this is kind of a weird question, but in the significant changes in assessment data to guide the plan of care. So we're really focused on, what's happening with the patient at this point in time, because we show in the second stage of shock, the mechanisms that control blood pressure aren't compensating anymore. The MAP's going to fall below normal limits, and that's such an important thing in shock is the MAP, and we'll talk about that more as we go. But your mean arterial pressure, which is your MAP, is going to fall, and that's going to be one of the guiding things with this. You always want your mean arterial pressure to be greater than 65. So if your MAP falls, you're progressing in shock, and that's not a good thing. Patients are going to be hypotensive at this point in time. So they're really getting sick. They're starting to show the signs of declining mental status. They may have, completely altered perfusion. So the respiratory system, it talks about that on page 290. Their lungs are going to be affected. They're going to be decompensating. Oftentimes they're going to need mechanical ventilation, which is why this person's probably getting transferred to the ICU. You're going to hear crackles. You're going to have decreased blood flow to the lungs. So you're going to have that patient's going to have CO2 levels that are going to be increasing and their oxygen levels are going to be decreasing. So they're going to need supplemental oxygen. Like I said, oftentimes they're going to have that via mechanical ventilation. So this person might be getting significant respiratory distress. And the other thing that you worry about is ARDS. And remember, we talked about that in the first lecture. So you want to be really, really, really in tune to this patient. Cardiovascular, they're going to be on a monitor because we're worried about dysrhythmias for this patient. Usually the heart rate's going to be really, really rapid. You might see a patient with supraventricular tachycardia that we talked about, or it could be a sinus tachycardia. They could go into many different dysrhythmias as well. Neurologically, like we said, the patient's going to be deteriorating. They might be really, really confused. They might be extremely lethargic, very hard to arouse, or they could potentially even lose consciousness. The renal effects, remember we said the mean arterial pressure is going to drop, and our mean arterial pressure is basically saying how is our body perfusing to all of our organs. How do we know that our mean arterial pressure is going down? We can calculate it. Most monitors, especially in ICU, is going to show it. That's one of our guiding principles in ICU, is what is our mean arterial pressure. You're also going to see the effects of that on the kidneys. You're going to look at your BUN and your creatinine levels. A lot of times they'll end up with an acute kidney injury as a result of this because their kidneys aren't perfusing, they're not functioning. So you're going to have an increase in your BUN and creatinine and a decrease a lot of times in your glomerular filtration rate. Your acid-base imbalances are happening at this point in time. And if you go back to table 14-1 on page 288, this patient is now in metabolic acidosis. Remember that the metabolic acidosis was starting in the compensatory phase, but the body was compensating, which was putting them into the respiratory alkalosis. So now the patient's not compensating, so they're beginning to have the signs of that respiratory acidosis. So if we were to pull their ABGs, remember their pH is going to be low and their CO2 level is going to be high because our respiratory is opposite. So if you do the ROME, respiratory opposite, metabolic equal, their CO2 level might be high. It might be normal too. The metabolic acidosis, you're going to see the pH low and the bicarb is going to be low because your metabolic is going to be equal. So you're going to have a low bicarb. HCO3 is going to be low and your pH is going to be low. You also sometimes at this point, like I said, are going to see the elevated CO2 levels too, but the patient is actually going to be in a metabolic type of acidosis because the anaerobic metabolism is taking place. How would you know that? You would know that because if you look at the way that the patient's levels are, and you can correlate it, and they're going to be in more of a metabolic state at this point. The association will be higher. If you have questions, I can clarify that, but just know that they're going to be in metabolic acidosis. I'm not going to give you something and expect you to figure it out in here. The other thing is sometimes they'll be in a mixed acidosis, which we talked about last semester, and I believe is audio recorded for you too. I'm not going to expect you to look at this and tell me that a patient in progressive shock, expect you to examine the ABGs, but I would expect you to know that a patient in progressive shock is likely in metabolic acidosis. So here is your next question. So with this type of shock, because the patient has a normal blood pressure, remember if their blood pressure is normal, I'm trying to drill this in your head, that's your compensatory stage of shock. The blood pressure is going to remain within normal limits. It's not until the second stage when they get to progressive where you'll see the patient become hypotensive with a mean arterial pressure dropping. So again, the mechanisms that regulate the blood pressure can no longer compensate. We start to see the blood pressure and the mean arterial pressure decrease. So the patient is hypotensive and they have a MAP that is less than 65. It's actually often even, pretty low. So when we see the mean arterial pressure drop, we know that they're progressing to the progressive stage from the compensation stage. All of the organs are going to suffer. So remember, we said you're going to be looking at your CMP at that point, and you might see your BUN and your creatinine levels increasing. There may be an alteration in your liver, but the big ones that you're going to see are your BUN and your creatinine. The vasoconstrictions continuing at this point too with cellular perfusion. So if you look at, if you continue to look at the different effects that you're seeing, it does talk about your liver enzymes in here too on page 291. So you'll see your liver enzymes elevated, your BUN and creatinine. Usually your BUN and creatinine are the ones you see first, but you can see any of your organ function will be altered when you get to the progressive stage. So you could see an alteration in any of those. So you're just looking at your CMP for that. Your gastrointestinal effects are going to happen as well at this point. A lot of times they'll end up with like a bloody diarrhea. The GI system is ischemic. Sometimes they'll end up with bacterial infections at that point too. Hematologic stuff, again, we said they're hypotensive. If they're having an inflammatory response, you might see bruising and bleeding. You're looking at the clotting time, so it's also important at this point. What you're looking at continually is your CBC. On your CBC, you're looking at your hemoglobin and your hematocrit. You're looking at your white blood cell count. Obviously, at this point, that's one of the things you're looking at, but it's not going to be, we're going to know if it's altered or not altered. Big things are your hemoglobin, hematocrit, your red blood cells. We're also looking at your platelets for risks of bleeding. We also worry about patient going into DIC, which is another complication of this. You're looking at your CMP to look at their liver and your kidney function. You're looking at their bleeding function. So you're looking at your PT, your PTT, and your INR levels. You're also going to have the patient on an ECG monitor from the beginning, from compensatory, because you want to be watching their conduction system and see what type of rhythm they're in. So that's really, really important. A lot of times, we're looking at their hemodynamic monitoring as well. Sometimes you'll see a patient with, that needs the closer monitoring. We don't see that as much anymore, really, as we used to, but you could potentially, if a patient's in progressive shock, see central venous pressures or anything done. Again, we said the lungs are failing. Pulmonary blood flow is going to cause a hypoxemia, so they might need, at this point, most often they're going to need mechanical ventilation, so we're going to be intubating them and putting them on a vent to control that. You also might see the patient at this point as well being sedated and sometimes neuromuscular blockade to try to preserve their cellular metabolism, which is going to be speeding up. As the MAP falls below 70, GFR, like we said, cannot be maintained. So that's when we're looking at the BUN and creatinine levels. Or liver function, GI function we just talked about. And DIC, like I said, is one of the big complications. So we're looking at the bleeding times to make sure that we are watching for disseminated intravascular coagulation. So DIC, one of the things that you look at for that is someone who has petechiae. You'll see, so they have, just trying to see what page it's on in your reading. You'll see that they're having periods where they're bleeding as well as, I'm just looking, in shock. It's on page 291, and I'm actually already on that page. So you'll see the patient having periods where they're excessive bleeding and clotting. So let's see. It's in chapter 33 where it's discussed more. So basically the clotting factors and the platelets are consumed and they require replacement therapy. So they're not only are they hyperclotting, but they're also bleeding. So a lot of times you'll see the patient needs blood replacement as well as clotting factor replacement in this. So what you look for in a patient with shock is they have usually like a weeping type of fluid coming from, it's like a serous fluid that comes from anywhere where they've had IVs, blood draws. It just sweeps out of old areas. So if they had blood drawn like 3 days ago, you might see weeping from that area. That's a sign that the patient has DIC. You're also looking for rashes, petechiae, things of that nature that signify bleeding, bruising, any of that stuff you want to be in tune to the patient's at risk for DIC. So our irreversible shock. At this point, organ damage is pretty bad. The patient's not going to respond to treatment at this point, and they're not going to survive. So really at this point in time, the organ damage is so severe that they're not going to be, there's really not a lot of hope for the patient. The anaerobic metabolism that we just talked about, they're going to have that is going to lead to the worsening of the acidosis. So the patient's the acidosis when you do your ABGs is just going to be getting worse and worse. It's not getting better no matter what you do. Their kidney and livers the function is failing. So they're basically going to be in liver and kidney failure. So we're just, you're just worried about it. MODS is going to be progressing. So you're going to see, all the organs are starting to shut down. it's only made usually retrospective. They're not going to say that it's this in this case until usually it's past this. Really, the thing at this stage of shock is really being supportive of the patient's family, talking to them, conferences and with the healthcare team and the family to make sure that they're understanding the prognosis is not good. A lot of times this is when palliative care is going to be brought in. I'll never forget my first patient with shock. He was a twin brother. He had MR and so did the brother, and they lived in a house together. And when he had septic shock, and we worked really hard on him. He had just lost his parents, and the sister had taken over care for him. And I'll never forget like looking at him, and when he got to that stage, there was nothing left to do. All of his organs were failing. He was completely unresponsive. We had him on the maximum settings on the vent, and he still had an oxygen sat that was like in the 80s. We just knew, he wasn't putting out any urine. Everything was shutting down. And I'll never forget the day that he passed away. They decided to put him on palliative care, and we decided to transfer him up to one of the medical surgical units from the ICU because there was so many of the people from the MR, the home that he lived in, that had MR, and they obviously weren't understanding it and grasping it. So the house brought in people to help, almost like one person per resident, to really help them, and they brought them all to say goodbye. And we transferred him up to the medical surgical floor, and everyone said their goodbyes, and he passed away. And it was honestly like I could cry even talking about it because I'll never forget him. And he was really like the characteristic signs of shock, and it just, no matter what we did, there was nothing we could have done. When he came in, he was already in the progressive stage of shock because they had missed the compensatory phase. He had been at the doctor's. He had had a urinary tract infection, which led him into the shock, and it was missed. And, there's nothing you can do. He didn't have the outward signs of shock, and he couldn't communicate a lot of what a normal person, without, mental deficits could have communicated. So by the time he was really sick, he was in the progressive stage, and he was just such a delightful guy. He was so full of life, and he declined so fast. I think it happened within 2 weeks, but you don't forget those. And that's why I say it's super, super, super important to be paying attention early, so that you can catch that compensatory phase. Here's a question. So your nurse is a member of the healthcare team in the emergency department. They're caring for a patient who is determined to be in the irreversible stage of shock. What would be the most appropriate nursing intervention? And the answer is A. Remember, we just talked. You want to provide opportunities for the family to spend time with them and help them understand the irreversible stage of shock. You want to make sure that they know that this is not, this is an opportunity for them to be in there and be with the patient, but that it's probably not going to be a good prognosis. Again, fluid replacement therapy is not going to be your priority. You're going to be doing fluid replacement therapy, but you don't want to tell them that they're not going to survive or that they will survive, because the chances of them surviving is slim to none at that point. Protecting their airway, and all the early rehabilitation process isn't necessarily the most important at this point, because we just said they're in the irreversible stage. They're likely not going to survive, and they're in multi-organ failure at this point. So again, for all types of shock, early identification, treating them quickly, identifying the causes, and then, the sequence of events is different for all. So we'll talk about that as we go, but management and the care is going to vary, but for the most part, the most important thing is early identification and timely treatment. Figure out what's causing it and deal with it. So your pathophysiology, again, for your hypovolemic shock, you have the decrease in blood volume, then the decrease in your venous return. The stroke volume is going to be decreased, therefore your cardiac output's going to be decreased, and you're going to have poor perfusion. So what does that mean for your patient? We'll get to that in just a second. I'm going to give you a question, and then we'll talk about that. So in the acute care setting, your nurse is assessing an unstable patient. When prioritizing the patient's care, the nurse should recognize that the patient is at risk for hypovolemic shock in which of the following circumstances. And it's A, your fluid volume circulating in the blood cells decreases. So we are looking at it starts on page 295. So again, it's the most common type of shock characterized by your decreased intravascular volume, which is your answer A. So basically what's happening is the volume somehow is being decreased, whether it is an external fluid loss or an internal fluid loss from shifting. So it could be trauma, severe dehydration, ascites, whatever the reason is, they're losing volume, and we need to treat it. So again, we just talked about the sequence. If you look at chart 14-3 on page 296, it actually talks about the risk factors. So your trauma, surgery, vomiting, diarrhea, diuresis, and diabetes insipidus. Your internal is going to be your hemorrhaging, your burns, your ascites, your peritonitis, and your dehydration. So again, that's on page 296 in Brunner, 13th edition. Medical management, we want to treat the underlying cause. Fluid and blood replacement, redistribution of fluids. When we say redistribution of fluids, if we need to give them something to pull it in, sometimes you'll see like albumin given. Whatever the reason is, we want to treat it by redistributing the fluid. Pharmacologic therapies, it talks about fluid replacement actually on page 297, table 14-3. So, it talks about crystalloids versus lactate ringers versus hypertonic saline. Again, the hypertonic saline, a lot of times we avoid because of the dangers of hypernatremia. But a lot of times what you're going to see is them either doing, you'll usually see them doing crystalloids like a normal saline, and they usually are going to do it wide open. Albumin, a lot of times, like I said, if we're trying to pull in from the fluids, depending on what the cause is, that can expand your plasma volume. You do see that given. It just depends, again, on when they figure out the cause and what's happening. Nursing management, again, you're going to be closely monitoring the patient. You're going to be administering bloods and fluids safely. Like I said, you want to make sure that a lot of times you're going to see that they're going to do a quick fluid challenge. They're going to make sure that they put the patient in the modified Trendelenburg position, which is on page 297. You're going to, lower the head and put the knees and legs up straight. Excuse me. But again, that's on page 297. Pharmacologic therapy is on page 297 also. And again, it depends on the reasons behind it. So just take a look at that. If it's vomiting, if it's diarrhea, we're just going to treat whatever the reason that they have it. We're going to try to treat that particular cause. There's our modified Trendelenburg, which we just talked about. And then we'll get into cardiogenic shock. So the big thing with cardiogenic shock, the patient is often going to have their decrease in blood pressure. They're going to have pulmonary congestion as a result, because remember, they've decreased cardiac contractility. The stroke volume and the cardiac output is going to be decreased. As a result, we have the pulmonary congestion, decreased perfusion, and decreased coronary artery perfusion. As a result, again, we're going to have a decrease in our blood pressure, decrease in our mean arterial pressure. You're going to see pulmonary congestion, so the patient's going to have adventitious lung sounds. A lot of times they're going to complain of chest pain, angina. They might have dysrhythmias. They're often going to feel fatigued because they have decreased cardiac output. And many times they'll have that feeling of doom. I'm going to die. I feel like I'm going to die. Something's really wrong. Listen to that. If a patient has cardiac issues and they start saying that to you, be in tuned with their vital signs, their assessment, and what's happening. And that feeling of doom is very much like you'll see when a patient has a heart attack. I'm going to die. Something's wrong. They're going to have hemodynamic instability, so they're going to often have confusion. They might be irritable. They're going to be tachycardic. Many times they're going to have a thready pulse, and they're often going to have a decrease in urinary output. So again, it's super important in all of the forms of shock to be watching the I and O. Medical management for cardiogenic shock is on page 298 to 300 in Brenner's 13th edition. Big issue with these patients that's different than the other shocks is you want to be super, super, super careful with fluid administration. So we want to figure out what the underlying cause is and treat it. If it's an MI, if it's heart failure, whatever the reason is that's causing the cardiogenic shock, we need to treat it. If it's a dysrhythmia, whatever. We're going to give them oxygen. We're going to try to control their pain. We're going to do hemodynamic monitoring. We're going to be looking at their lab value. So we're going to draw some cardiac enzymes on them. So remember, we're looking at our troponin, which is our gold standard for MI. We're going to be looking at our sorry, my brain is out of whack here. Our CBC and our CMP, we're going to be looking at our risk for bleeding, so we're going to be looking at our PT, PTT, and INR. And we're looking at our CKMB, that's where I'm going with this, to make sure that we're looking for that at heart, and then our BNP for, so CKMB, troponin, looking at cardiac function and cardiac damage. The BNP, the B-type natriuretic peptide, is the one that we're going to be looking at for your heart failure. Sorry, I don't have notes on all these, so I'm trying to remember a lot of this. So the big thing when I was going with heart failure and fluids is we worry about these patients. If you give them fluid too quickly, they can have really quick decompensation. Think about heart failure and overload of the heart. So anytime you have a patient with cardiogenic shock, you want to be very, very, very careful when you're administering fluids, and you always give them slow. Pharmacology for cardiogenic shock is going to be on page, I'm just looking here, starts on page 299. So your dobutamine, obviously is the inotropic effects. Nitroglycerin, which is often given IV for vasodilation to reduce your preload. Your dobutamine is your sympathomimetic, and that's basically going to be vasoactive. The big thing with these is we titrate them, and they always like to ask a question about, what you do with the medication, and you're going to titrate it to their vital signs, their MAP, and the patient condition. So you're looking at their cardiac output, see what's going on, and they'll basically have you titrate it to make sure that their patient is adequately perfusing. And the other thing is we usually give this, these medications in an ICU. No, usually we always will be giving these in an ICU setting, and they're usually given through a central line. Other vasoactive medications in here are on page 300. So that's just talking about your norepinephrine, your epinephrine, vasopressin. So any of those, basically, they're going to be stimulating your sympathetic nervous system, which, remember, is your fight or flight. So that's going to increase your heart rate, increase your blood pressure, those types of things. Your antiarrhythmic medications will be given based on what the arrhythmia is that's happening. So that you would really be dependent. So again, if we want to try to prevent cardiogenic shock, that's going to be our gold, standard. We want to try to not have cardiogenic shock. We're going to be closely monitoring anyone with any type of cardiac issue for their hemodynamic status. So we're looking at their blood pressure, their mean arterial pressure. We're looking at their labs. We're looking at everything to see what is happening with them, their heart rate, their cognition, and obviously pain. Administering medications and IV fluids. Again, we said IV fluids are done very, very slow. If they have an intra-aortic balloon counterpulsation, we want to make sure we're monitoring that. Some of you guys at Ellis have seen that. I'm not sure if you're seeing that at Samaritan, but if you have the opportunity to look at it, make sure you ask. It's definitely one of the things that you'll see in a patient with cardiogenic shock. Ensuring safety and comfort is also the other important thing with these patients. So here's a question for you. The nurse is caring for a patient admitted with cardiogenic shock. The patient is experiencing chest pain, and there's an order to administer morphine. In addition to pain control, what is the main rationale for administering morphine to this patient? And the big thing with this, again, is D, and I don't think this is in your reading. It is in your reading. Sorry. It's on page 299 under initiation of first-line treatment. The answer is D. In a patient experiencing chest pain, morphine is administered for pain relief. In addition to that, morphine will dilate your blood vessels. That's gonna therefore reduce your workload and decrease the cardiac filling time, which is your preload. And it's gonna also reduce their pressure against the heart muscle to eject, which is your afterload. So it's gonna basically decrease your preload and reduce the pressure in your afterload. The morphine is also going to help the patient with anxiety too, because think about it, they're having chest pain, they're going to cardiogenic shock. We want to make sure that we're dilating their vessels for all these reasons, but it will help with pain, it'll help with anxiety, it'll help with the preload and afterload, but it'll also dilate your the blood vessels. So your nurse is overseeing care in ICU, reviews the shift report of 4 patients. The nurse recognizes which patient to be at greatest risk for developing cardiogenic shock. And it is B, your patient who's had a myocardial infarction or has any other cardiac issue. Malignant hypertension isn't really the big one. It's going to be your MI patients. I'm looking here to see if they have it. Yes. Patients, it's on page 298 in your textbook in Brunner's 13th edition. A patient who experiences an anterior wall MI are at greatest risk for cardiogenic shock because of the potentially extensive damage to the left ventricle caused by occlusion of the LAD, coronary artery. So it's really, really important with your MI patients. So your critical care nurse is caring for a patient who is in cardiogenic shock. What assessments must the nurse perform on this patient? So what are your priority assessments for this patient? So your initial assessments that are going to be really the big ones are B, C, and D. Your cardiac rhythm, your fluid status, and the action of the medications. The sputum volume is not important at all, and your platelet level at this point really also isn't super important. It might be good to look at, but it's not going to affect their shock. Their shock's going to be addressed by their fluid status, their rhythm, and the action of the medication. So we want to know what meds we're giving, why we're giving them, and deal with it at that point. All right, your circulatory shock starts on page 301, and I'm going to go through here quickly. So your circulatory shock, your patients with circulatory shock, remember there's the different forms of circulatory shock. You have your septic shock, your neurogenic shock, and your anaphylactic shock, and we're going to go through those one at a time. So you have your precipitating event, which is basically what it always comes back to. We need to figure out what that is and deal with it. You have your vasodilation, you have the inflammatory response, the maldistribution of your blood volume, your decreased venous return, your decrease in cardiac output, and your decrease in your tissue perfusion. They'll all have that pathophysiology, but the mechanisms are what's going to be different in this. So that's important to look at. And again, it starts on page, really at the very bottom of 300, and it really starts on 301. So go ahead and read this question. So you have your, the nurses here, again, are reviewing the similarities between the classifications, and we just talked about classifications of circulatory shock. So it's going to be A, anaphylactic, D, septic, and E, neurogenic. So I'm not going to elaborate this. We just said it. So it's your septic, neurogenic, and anaphylactic. So a nurse is in ICU and receives report from another nurse in the ED about a new patient being admitted with a neck injury he received while diving into a lake. The ER nurse reports that the blood pressure is 85 on 54, the heart rate is 53, and the skin is warm and dry. The ICU nurse recognizes this is probably, and it is B, neurogenic shock. Neurogenic shock starts on page 304 in Brunner 13th edition. The key things in this area, again, starts on page 304. Sorry, I'm back. I can't stop coughing. Next slide. Oh, didn't want to bring up a map. I apologize. This is how you know this is in real time. Okay. This table I pulled off the internet. So basically what you want to look at here is that The difference with the neurogenic shock, when you look at this, the patient has bradycardia, not tachycardia. The difference with this is the parasympathetic nervous system is taking over. So remember, in all of the other forms of shock, your sympathetic nervous system is what's kicking in, which is your fight or flight. While in your sorry, I'm trying not to cough here. The neurogenic shock, your body's going to initiate the parasympathetic nervous system. The way I always remember this is, when you have a neurogenic shock, it's basically some kind of an effect or an issue with your spinal cord, whether it's a spinal cord injury or spinal anesthesia. And so the mechanism of action is affected with our autonomic nervous system. And instead of the sympathetic, our spinal cord's actually sending out parasympathetic response, which is your rest and digest, is how I always tell people to remember it. So your sympathetic's your fight or flight. And when we have damage to the spinal cord, which is what happens with our neurogenic shocks, our parasympathetic system is going to take over, which is rest or digest. So there's enough blood. It's just that the blood vessels are dilating and the volume's displaced in these things. It's injuries and often that occur that affect the nervous system. And basically what happens is those nerves in the spinal cord, instead of the body's normal reaction would be the fight or flight, where we see the tachycardia with these patients, that mechanism's not working and they're going to have the opposite. They're going to have bradycardia, because they have the parasympathetic response instead of the sympathetic. So your patient with massive trauma and spinal cord injury is admitted to the emergency department, which finding by the nurse will confirm a diagnosis of neurogenic shock. Remember, the difference with this is our bradycardia, so C is our answer. Neurogenic shock is characterized by hypotension in bradycardia. The other findings are more consistent with the other types of shock. So this patient's going to have a low blood pressure and a low pulse. So that bradycardia is often the thing you see on NCLEX questions, because it's what's different in this form of shock. How are we going to treat it? We want to stabilize the injury or treat the cause of the shock. If it's spinal cord injury, you want to stabilize them. If it's spinal anesthesia, a lot of times it's from positioning, because the head of the bed you want to have when they have spinal anesthesia or epidural anesthesia, you want to make sure the head of the bed is at least 30 degrees. This is on page 305 in Brunner's 13th edition. And also we want to make sure we're preventing thromboembolism with these patients. So prophylactic meds, passive range of motion, compression stockings, and devices are also important. So when the charge nurse is evaluating the skills of a new RN, which action by the new RN indicates a need for more education in the care of patients with shock? Your answer here is C, decreasing the room temperature to 68 degrees for a patient with neurogenic shock. Patients with neurogenic shock often will have issues with maintaining their temperature, so the room temperature should always be kept warm to avoid hypothermia for these patients. The other actions by the nurse are appropriate. So after receiving a liter of fluid, the central venous pressure for a patient with septic shock is 10, but the blood pressure is still 82 on 40. The nurse would anticipate administration of what? Your answer here is C. When fluid resuscitation is not successful, vasopressor drugs are administered to increase the systemic vascular resistance and improve your tissue perfusion. Nitro would be given to decrease the preload and further drop your cardiac output and blood pressure. The Zygris, actually, there's a spot in your book under the septic shock where it will tell you that it's actually been proven that Zygris is not an effective drug. So that drug is actually not given anymore. They stopped in like 2009. All the studies were showing it was not effective. And then the nitroprusside or nipride is an arterial vasodilator and would also further decrease your systemic vascular resistance. Sepsis, I actually posted another article on sepsis. Your book's got pretty much everything that you need in it. But right now, so the last sepsis guidelines, actually I think were 2012. They're published in 2014. And the article that I posted, there's actually a link that's available through the library. It's called Scripting Nurse Communication to Improve Sepsis Care. This is actually an article that was released in 2006. So it's a newer article than the one that was originally posted, and it's got a lot of the same information. But what it talks about in here, there's a good review of the literature. It's got the sepsis screening criteria on page 235, which is really important. But it actually talks about how they're integrating the sepsis program into the electronic health records. A lot of times now, you don't even realize it when you're documenting, but by documenting and making sure you're documenting everything accurately, you're actually going to flag yourself if a patient is meeting these criteria. It should start to kind of clarify. So lactic acid levels, blood cultures, how often they should be screened. This is all in the response area, which is 237. It's talking about all these things in tests and post-tests and how the nurses, the implications of the study, and how people recognize it. So it's just kind of important, and it talks about, what we need to do, what we need to say, and how these are implemented in the electronic health records. The other one, the other article, I did also pull here, and the stuff from that's important. Really, it's only a couple pages long. I have it in my office if anyone wants to come and look at it. You're welcome to do that rather than go search for it. It just talks about the variables of sepsis, which is your heart rate, your temperature, your altered mental status, edema and fluid balance, hyperglycemia, your inflammatory variables, your hemodynamic variables, and your organ dysfunction variables, which we're going to be talking about in this as well. But I do have a copy of that if anyone wants to come and take a look at it. I will have it with me in Beeps this coming week if anyone wants to look at it or needs copies. You can take a look at mine. So page 301 to 303 talks about sepsis, the causes of sepsis, and the reason that we're seeing so much sepsis is really the increase in invasive procedures, healthcare-associated infections, and the resistance of the antibiotics. And, we're seeing so much resistance now because there's so much prescription of them. Overprescription, lack of cultures prior to prescription. There's quite a bit of stuff. With prevention, really it's strict infection control practices, and everything you read is going to say, wash your hands, wash your hands, wash your hands. It goes back to the basics. Programs to get central lines out, get people, get catheters removed and not put catheters in. That's why we're seeing less urinary catheterization. Getting people off vents and the tubes out. So really get the tubes out. Anything that's invasive, we want to either restrict the use or get them out. Early detection, chart 14-5 on page 302 in Brenner's 13th edition is a really good chart. 302. 14-5 on page 302. I'm going to the wrong page here. That one talks about, early identifications on 303. The promotion of recognition is on page 302. So 302 has like your SIRS criteria and what you're looking at with SIRS. And SIRS is basically the same as, it's pretty much the same thing as sepsis without an identifying cause is the way that they'll define that in when they diagnose or discharge. When you have a patient with sepsis, you have a known cause. Usually you'll have positive blood cultures. They may have other signs of infection or they're already on antibiotics. And I'm on page 303 right now. So there's a lot of things on there. The lactic acid levels are increasing. And remember, when the oxygen is low, the carbohydrate breaks down energy and makes lactic acid. So the levels will go up with exercise, they'll go up with heart failure, severe infection, and shock. So when we start to see lactic acid levels increasing, we want to be thinking sepsis or shock, heart failure, any of those things, but usually it's severe sepsis and shock that you're going to see that in. Treatment, cultures first. Culture. When someone has signs and symptoms of sepsis, the first thing that you're going to do is culture everything. And you'll see a lot of times, that you'll see cultures ordered and you'll see antibiotics ordered. It's really, 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 really crucial that you get those cultures before you administer that antibiotic. I've got the lived experience. Really, you want to make sure what you'll see when they have signs and symptoms of sepsis. You're going to see them doing cultures of the blood, urine, sputum, anything. If they have a line in, they're going to culture the line. They're going to culture everything. Aggressive fluid resuscitation is also super important. You're going to see that, they're going to be, usually they're going to do a quick fluid challenge, like a liter in as fast as they can. Sometimes they'll do 500 in a half an hour and then another 500 in a half an hour. So aggressive fluid resuscitation, you're watching their vital signs very, very carefully, especially their blood pressure, their urine output, and their lactic acid levels. So their lactate levels, again, you want to be very, very careful in aggressive treatment if their lactate levels are greater than 4. So under 2 is expected in a patient who is sick. It's normally under 1, but anyone over 4 is pretty much that's a sign that they need aggressive treatment, and that's a clear risk of sepsis. So you want to note if someone has that level, it's crucial that you report that right away. Other things that we'll use for treatment: vasopressors, inotropic agents. You'll often see packed red blood cells. That's not because of blood loss. It's usually because we need to help with the delivery of oxygen. So it's not that they're losing blood. It's that they're not getting enough oxygen. And by giving them packed red cells, we're getting more oxygenated cells to their system. Sedation and neuromuscular blockade is often used to decrease the metabolic demand. So we might sedate and neuromuscularly block the patient. Watching their labs, so your CBC you're watching, it's not just the white count, because often we know that it's sepsis. We know they have an infection, but we're also looking at their hemoglobin and their hematocrit, their platelets. We're looking at their CMP because we want to watch their kidney function. We're looking at their AST and their ALT for their liver function, watching and make sure they're not progressing. And the intake and output is super, super, super important in these patients. So you want to be also watching that pretty closely. I'm going to show you a picture. One of them is a little graphic, so I'll give you the heads up on that. But I'm going to tell you my story of sepsis. So this would be my husband. And if you look at these pictures, the first one over to the left was the second time he was actually admitted with sepsis. He had a medical complication. He ended up with a hernia and had hernia surgery. Because of a medical error, he had a delay in surgery and had a pretty bad infection. So we had to wait for the strangulated hernia to be removed because he had to have antibiotics. As part of the hernia surgery, they put in a mesh, and I'm sure all of you guys have seen all the commercials on TV with mesh. But what happened with him is he ended up with a mesh infection, and it didn't show up on any of the CAT scans, so it was missed. So what happened was the first surgery was in April of 2015. He never felt good. He wasn't super, super sick, but he just didn't feel good. So that infection was kind of festering inside of him for quite a long time. He returned to work. He just didn't feel well. So he ended up leaving work, and by November, he ended up with another hernia. We had to wait for approval for insurance for surgery. In January, he had his second hernia repair, and it was another one. It was stuck, but it wasn't intestine, so they waited until January. January 11th, he had his second surgery. He ended up, after the second surgery, he dehyssed. When he dehyssed, he also ended up with an infection. We went home on antibiotics after that, dealing with it at home. And about a week later, he ended up in the hospital and septic. He was admitted that time for 4 days. They did very aggressive fluid challenges. When he came into the hospital for the first bout of sepsis, the thing that's important, and I'm going to tell you to look at page 302. So one of the things that was different about him and the way that it was almost missed is that his temperature was actually really, really, really low. When he came into the hospital, his temperature was 96.1. He was tachycardic. His respiratory rate was really high, and his oxygen level was kind of low. I mean, he has no health history. He had no health history. So his oxygen saturation was only like 92%. But in normal, it wasn't really picked up right away. It wasn't until his white count came back, and his white count was actually also super low. His white count was like, I want to say like 2,500. But guess what? The doctor really listened to us, and he drew a lactic acid level, and his lactate level was like 4.2, I think, that time. So he got admitted. They immediately started fluids. The nurses were fantastic. They cultured his wound. They cultured his sputum. They cultured his pee. They cultured his blood. They did everything. Aggressive antibiotic treatment was done after the antibiotics were given. And he improved. He did really good. We went home on an oral antibiotic, and he did pretty well for a while. He finished the antibiotic, and it was almost 6 weeks to the day. He collapsed again. He had now gone back to work. He collapsed again, was brought by ambulance, and that was our second bout of sepsis. This time he was much, much worse. He had progressed this time he presented with a temperature that was about 102. His heart rate was in the 120s. His oxygen saturation on 2 liters of oxygen was in the 80s. He was about 82 to 84. That picture on the upper left-hand side was actually that day. It was actually 24 hours after he was admitted to Albany Med for sepsis the second time. His respiratory rate was high. His white blood cell count at this point was actually really high too. He had gone from the low the first time with sepsis to the opposite. He was high. He was about 14,000, I think, when we got admitted. He ended up jumping up to about 21,000. The problem with this is that they didn't do cultures this time. They knew it was sepsis because his lactic acid level was high. They did do blood cultures, but his wound hadn't opened this time, so they didn't do anything with the wound. I think they got a urine culture and a blood culture. However, with this, he had just been on antibiotics, and his culture was negative. His CAT scan was negative. So they did what they call a white blood cell scan, and that's up there in the middle. They scan his entire body to try to see where the white blood cells go to. And there's normal areas that you see white blood cells, like your stool, your GI system, and everything. Again, it came back negative, and the reason that it probably did, the infection disease doctor said, is because he had been started on broad-spectrum antibiotics prior to the tests, which is why I say it's super, super, super important that you don't wait to do the tests. You want to make sure you do the tests, all the cultures, before you start the antibiotic, because the antibiotics are going to work quick. And remember, when we have these patients with sepsis, we're starting them on broad-spectrum antibiotics, and usually multiple broad-spectrum antibiotics. We're going to kick this microorganism out of their system pretty quickly, hopefully. So if we don't have the cultures, we're not going to know what it is. This time when he came in, his serum lactate level was probably like 6. He was pretty sick this time. One of our graduates took care of him in the ER and just did fluid, and prevented him from being intubated. He was pretty close this time to ending up intubated. And he wasn't, thankfully, to one of the ER nurses at Albany Med, who was a Hudson Valley grad and was fantastic. But he had a fever. That bottom left-hand picture was actually like 48 hours, maybe even more. It was probably 72 hours after admission. He still had a fever. He was fighting. So he ended up, they couldn't figure out what it was at this point in time, and decided not to do surgery because he was so sick. And again, we went home. Come August, that's your top right picture, was our third bout of sepsis. This time he came in. When we came in through the emergency room this time, again, his temperature was actually normal. He was just starting in, which I think he was slightly elevated. He might have been like low 100s, but he was tachycardic at that point. His respiratory rate was high, but his blood pressure, and all these other ones I forgot to mention, his blood pressure was always really low. This time he came in, his blood pressure was actually elevated. I'm sorry, it wasn't elevated, it was normal. So the third time he came in, which is that bottom right-hand picture, you see his belly. He'll kill me for putting this on here, but his stomach is normally not this large, and I'll tell you the reason why it's this large in a minute. But he had signs and symptoms of a localized infection, obviously, at this point, which is why they kept him. He was in compensatory shock at this point. They're the compensatory stages of shock. He was starting to go into shock at this point, and it was starting to go into a septic shock. His vital signs were maintaining. Although he was tachycardic, his blood pressure was totally normal. His oxygen was on the lower side, but it was still only it was like 94, 95, low for him, but normal. So he was doing pretty good. His white count was also, the initial white count was totally normal. So they weren't really sure what was going on, but because he was in so much pain and it was our second day back to the hospital, they admitted him. They saved his life that day. They had a trauma surgery at Albany Med. He literally saved his life. because come that next morning, that's that top right picture. By the morning after he was admitted, it was August 22nd of this year, he had decompensated so bad that he was starting, he was septic at that point. He had all the signs, his oxygen dropped, his white count went really high. He had a fever. He was really, really sick. And as soon as the doctor saw that, they actually took him and brought him right to the OR. That stomach on the bottom was because he had a massive abscess in his abdomen, and it was a mesh that was infected from that original surgery that had been more than 14 months prior at that point. So he had been all these bouts of sepsis from that. So they actually went in and removed it that day. And he was treated. He didn't need the medications, but he did need all the fluid challenges and the antibiotics. Obviously, the cultures came back. When they finally cultured, he had 8 strains of bacteria. So literally, they saved his life that day. And the reason I tell you this story and the reason I'm giving you the personal data here is because he was 2 times the shock was missed, or the sepsis was missed, and he finally, the 3rd time, it wasn't until he was starting to go into shock that it was caught, it was treated, and it's that easy to miss it. I'm a nurse, I was an ER nurse, I was an ICU nurse, and I knew he was that sick, but I guess, and I knew to get him in. If I wasn't a nurse, what would have happened? So it's really, we need to start treating, we need to start looking, we need to start assessing, and we really, really have to be in tune with these things. So if you look at the right one, that picture was post-op. Because the infection was so severe, they couldn't close his abdomen completely, so I ended up having to pack the wound for a few weeks until it closed. It was really, really deep. And he's since had more surgery, but literally that saved his life. The recognition of sepsis in the fact that the nurses were on top of his vitals and noticed that his urine output had been decreased, and his actually B1 and creatinine were also elevated. Those were the early signs, and if they hadn't been watching those and the doctor hadn't been suspicious of this being his 3rd bout going septic, he could have died. He was pretty close the 2nd time in that top left picture. He almost ended up on a ventilator. In that bottom time, I'm convinced if they hadn't gotten him to the surgery that day, it would have been a much different outcome. So those early signs and symptoms are super important for you guys to pay attention to and to recognize. Off my soapbox. So when you're caring for the patient who has septic shock, which assessment finding is most important for the nurse to report to the healthcare team? And it's B. It's that cool, clammy skin, because the patients in the early stages of septic shock are going to have warm, dry skin. The patient who begins to get cool and clammy indicates the shock is progressing, and the other information is important to report, but it's not going to indicate deterioration of the patient's status. Your low blood pressure, your tachycardia, and your oxygen saturation are normal findings in that compensatory phase, but when that person is starting to deteriorate and get to the progressive stage of shock, that is that point where that cool, clammy skin is a good sign that you need to get them, an intervention quick. So again, like I said with my husband, he had that blood pressure that was low, he had the tachycardia, he had the low sat, but that next day, August 22nd is a day I'll never forget. I mean, he was cold, he was clammy, and he was, he looked terrible. He was progressing at that point, and that is when you have to really pay attention, is when that person doesn't have that red dry that you see in the upper left-hand picture that I shared with you. The one, when they start to get that cool, clammy feeling is when you want to be nervous and be really aggressive. Assessing the nurse is caring for a patient who is progressing infection places her at risk for shock. What assessment finding would the nurse consider a potential sign of shock? Again, it's the shallow, rapid respirations. The systolic blood pressure being elevated is actually good, because remember, with shock, it's low. An elevated mean arterial pressure is what we want to see. A low mean arterial pressure, less than 65, we want to be concerned. Remember, a map of less than 65 is concerning. We want it greater than 65. And bradycardia is not a sign of anything except for neurogenic shock. So if we had an infection, we're at risk for septic shock, and that tachycardia is the sign that we're going to see. Anaphylactic shock. So your triage nurse, a triage nurse in the ER is on shift when a grandfather carries a 4-year-old grandson into the ED. The child was not breathing, and the grandfather states the boy was stung by a bee in a nearby park while they were waiting for the mother to get off of work. Which of the following would lead the nurse to suspect that the boy is experiencing anaphylactic shock? The answer is B. You're going to go to page 306 in Brenner's 13th edition, and basically what you're going to see here is that the B is the rapid onset of respiratory distress. With anaphylactic, you have acute onset of symptoms, which is respiratory compromise, reduced blood pressure, GI distress, skin and mucosal irritation. It usually happens within the first 5 to 30 minutes of exposure. So the thing with this is you need to act fast. Fluids, epinephrine, which can be intramuscular if you get them in the ER, and you're lucky enough to do that. Sometimes you do the IV, Benadryl. Usually we'll do that IV. Albuterol nebulized is going to help with the reversal of the histamines, the histamine-induced bronchospasm, so it helps with their respiratory. So they might say, well, why the heck are you giving them a nebulizer? It's not because they have asthma or they're having an asthmatic reaction, which a lot of times you'll hear them say. It's because we want to reverse the histamine response and reduce the bronchospasms. Let's see if we can switch here. So management of shock, again, we talked about the fluid replacement. We want to be very careful with our patients with cardiogenic shock that we don't go too fast. Vasoactive medications we talked about, and nutritional support is also super important with patients in shock, whether it be through central line, we're giving them parenteral, or if we're doing enteral nutrition, whatever it is, we want to make sure that we're very careful. Fluid replacement, again, I talked about normal saline or lactated ringers. Sometimes you'll see the hypertonic, but again, most often you're going to see the normal saline. You just have to be careful with the hypertonic about the elevated sodium levels. Cholates, a lot of times you'll see albumin. We talked about that. Dextrin, the only thing with that, you don't see it as much because of the platelet aggregation. Blood components for hypovolemic shock. You can also see blood components given to increase the oxygenation to cells and other forms of shock. Complications of fluid replacement, again, you worry about fluid overload and pulmonary edema, and you're going to monitor this by, looking at their vital signs by listening to their lungs. IVs for hypovolemic shock. So the nurse is caring for a patient who is exhibiting signs and symptoms of hypovolemic shock following injury suffered in a motor vehicle accident. The nurse anticipates that the physician will promptly order the administration of crystalloid IV solution to restore intravascular volume. In addition to normal saline, which crystalloid fluid is commonly used to treat hypovolemic shock, and it's lactated ringers. Again, the 3% normal saline, a lot of times I said they'll avoid that because of the my brain's not working, sodium, but also you want something that's isotonic when you're administering them at this point for these patients with hypovolemic shock. Fluid replacement. You are precepting a new graduate in an ICU. You are collaborating in the care of a patient who is receiving large volumes of crystalloid fluid to treat hypovolemic shock. In light of this intervention, for what signs should you teach the new nurse to monitor for in this patient? Your answer for this is A, hypothermia. On page 298, it talks about hypothermia being an issue that you watch out for with these patients. So sometimes they need support, warmed fluids, a bear hug, or something to keep them warm. But hypothermia is one of the things that they need to monitor for with a patient who is in hypovolemic shock. Other things you're going to see a lot of times is difficulty breathing, pulmonary edema, decreased urinary output. You're often going to see with these patients that they have tachycardia. Coffee ground emesis isn't a finding, and you often don't see pain with hypovolemic shock. Vasoactive medication. So the nurse is caring for the patient in ICU whose condition is deteriorating. The nurse receives orders to initiate an infusion of dopamine. What would be the priority assessment and intervention specific to the administration of vasoactive medications? What's super important, and we talked about, is A. On page 294, it talks about this. You're going to be making sure that you're frequently monitoring their vital signs, looking and watching their central line site, and providing accurate drug titration. So your vital signs are every 15 minutes at least. You want to make sure you're administering vasoactive drugs through a central line and you're titrating them for a mean arterial pressure greater than 65. Remember, we talked about that. The mean arterial pressure should be greater than 65. You never want to stop them abruptly because it could cause hemodynamic instability and lead to shock. So you always are going to titrate them. Again, we talked about the vasoactive medications. They're used when fluid therapy alone is not maintaining the mean arterial pressure greater than 65. They're used to support hemodynamic status and stimulate the sympathetic nervous system, which is part of your autonomic nervous system. We're watching the vital signs. Again, we said every 15 minutes or more often if needed. A lot of times you'll see that a patient would have an A line or some type of central line that's going to be watching, usually an A line if they need one, to watch continuous blood pressure and make sure they know where the blood pressure is at all times. We talked about giving them through a central line. We worry about extravasation if they did it through a peripheral because the extensive tissue damage if there was extravasation. Doses, again, they're going to be titrated to the patient's response. So we're watching their mean arterial pressure, we're looking at where they're at, and we're making sure that we titrate to a therapeutic level. So the patient who is in shock is receiving dopamine in addition to IV fluids. What principles should inform the nurse's care planning during the administration of the vasoactive drug? And it's B, the drug dose is going to be tapered down once the vital signs improve. So we're looking at the pulse of blood pressure and we're looking at the mean arterial pressure, and we're going to be saying if the patient's improving, then the drug needs to be decreased. So they're going to slowly decrease it. They're not just going to stop it to make sure that they can adequately perfuse the patient. Nutritional support for the patient. Again, we want to make sure we're meeting their metabolic needs and energy requirements and preventing catabolism. So we want to support whether it's parenteral or enteral nutrition. The GI system, we want to use it to prevent it from sloughing and having issues. The other big thing that you're going to see a lot of times with these patients is H2 blockers or proton pump inhibitors to protect the GI system. So the intensive care nurse is caring for a patient in shock, and they're planning assessments and interventions related to the patient's nutritional needs. What physiologic process contributes to these increased nutritional needs? And it's C, the release of the catecholamines that create an increase in the metabolic rate and caloric requirements. And our catecholamines are our epinephrine. It's part of our sympathetic nervous system. Psychosocial support, again, big thing with these patients and with their family members. They're going to be anxious. You want to support them. You want to talk to them. You want to let them know what's going on. Communication is super important, not only with the family and the patient, but also with the other people in the healthcare team. Don't assume that they see the labs or that they see what's going on, and make sure that you're communicating with them when there is a change in patient status. I will tell you, with my husband, when he got sick, I actually knew the nurse that was in the OR with the doctor that day, and I was the one that texted him when the vital signs were going down, and when I heard what the CBC came back as, and I said, he is getting worse, something needs to happen, and he was in the OR within 15 minutes. So as a nurse, that's really your responsibility to make sure that you're watching this, but also communicate with the family, because that family member might be the one in the room when the blood pressure is taken, or when they notice that the heart rate's gone up. That family member might be the one who says to you, hey, you know what? I noticed their blood pressure. I noticed this, or I noticed this change. If they understand what's going on and they understand what to look for, it might help you as a nurse as well. End of life issues, like I said with the guy that I had that had the septic shock. We talked to the family, we explained to them what was happening. It was heart-wrenching, and you will cry. The grief processes, explaining that to the family, explaining that to the patient, and kind of understanding that yourself, because a lot of times you get attached to these patients and you don't have them for a day or two. Sometimes you'll have them. That particular guy I was talking about, I took care of him for like a month before he passed away, and it was just every day we would come in, you'd have glimmers of hope, and then it'd be defeat. And as a healthcare team, you're going to support each other through that too. Mods is another important thing. And I'm just looking to see, that is on page 306 and 307 in your book. So MODS basically is a complication of any form of shock. It's most commonly seen in patients with severe sepsis. It's resulting from inadequate tissue perfusion. With MODS, basically, there's the presence of altered function or 2 or more organs in an acutely ill patient. So you might see that their kidneys are not functioning, their liver's not functioning, they might be on heart failure. It can be primary MODS or secondary. Again, they're not really sure, the cause in some cases. It has a very, very high mortality rate. 75% of patients who progress to MODS are not, don't stay alive. They die. The mortality rate is that high. Treatment basically is controlling the initiating event. We want to figure out what caused it, treat it, try to deal with it, promoting adequate tissue perfusion. So this patient, you're going to have them on multiple medications. We're going to be titrating multiple drugs to try to figure out how to treat them, providing nutritional support, and then promoting communication, frequent communication within the healthcare team. We want to, if they do survive MODS, we want to be talking to them about rehabilitation and progression and any of the stuff that can happen after. So again, promoting them and also knowing their wishes and being consistent with what their wishes are. So last question. The ICU nurse is caring for a patient with MODS. What nursing action should be prioritized at this point during care? So it's really providing the information and support to the family members. Most often it's not a long recovery process. It's often not a recovery process. So you want to be open and honest with the family members and let them know that the prognosis is not good. Educating the patient regarding the use of supportive fluids. At this point in time, the supportive fluids are not going to be really effective, and most times this patient's not going to be one that you can talk to. Facilitating the rehabilitation process of treatment. You're not rehabilitating them at this point. You're trying to reverse the sign, the effects, reverse the cause, and control the initiating event at this point. You're trying to get their organs to perfuse and save their life, but at this point it's not rehabilitation, it's treatment.